Hi everyone, I'm super excited to have Dr. Meredith Provost on today's Fertility Expert Q&A series. The number of questions that I got for this Q&A were by far the most that I've ever received, and they were so good, and I feel like they can really help a lot of people out there. So I'm just going to jump on here, and I'm just going to see if Meredith is on yet, and I'll just invite her on. So hi guys, thank you everyone for joining. Super excited to have Dr. Provost on. There she is. I'm going to add her right now. I'll be up here in a second. So I hope everyone's having a really nice day. And as you know, if you're there, she is. Hi.
Hello.
Thanks for joining. We're both wearing blue. My necklace matches your shirt. That's awesome. Okay, so I just want you to tell us a little bit about yourself.
Yeah, so I'm Meredith Provost. I'm a reproductive endocrinologist, just like Dr. Aimee, and I'm here in Indianapolis, Indiana, where I'm in a private practice here in the Midwest.
Awesome. And just tell us a little bit more. I mean, that's not all you are. I mean, you have quite a number of accomplishments as an athlete, you're a PhD at University of Cambridge. So just tell us a little bit about that. And I know you inspire young women through your TikToks, and talk a little bit about that too for us.
Yeah, so before I went to medical school, I did a PhD at Cambridge. I was first headed to the medical school in the United States. I ended up deferring because I got a Gates scholarship to go over to Cambridge to do a master's degree, and ended up staying and doing a PhD in the history of science. So I have my PhDs in history before med school. I went back to medical school, did my medical school at McMaster University in Canada, residency in Arizona. I did my fellowship in reproductive endocrinology at Duke. In undergrad, I played volleyball. I was a volleyball player at NC State. So I've done a few things. Mom of two here, drive a minivan. Apparently people are hearing about that now. So I'm having some fun dancing on TikTok too.
And you're also a boxer.
I was. When I was at Cambridge, I boxed for the University of Cambridge. I was on the men's team, but I fought against women. And I was, I think, the second woman to box for a university in the UK. So kind of cool times.
That is cool. Okay, well, let's just get to it. We have so many questions to get through, and we hope to get through all of them. And I know people will start chatting their questions as well. So let's get to the questions that we had emailed. So here's the first question. My doctor hasn't said anything about why she thinks I'm not getting pregnant, but says it could be because of my husband's sperm count. It's low, between 10 to 20 million. My question is this: if you're not seeing any issues with a woman, no cysts, fibroids, tube issues, and regular periods, is IUI route the way you would go? And what are your thoughts on supplements or medication to increase sperm count?
Yeah, I mean, I thoroughly believe that men need a fertility workup just like women do. So for me, you know, when I see numbers like that, I want to get a full history on the male and figure out any exposures that he has, substance he's using, those sorts of things. I often want to get labs on him and see what his testosterone levels are and things like that. I often will send these guys to my friendly reproductive urologist down the street and have them do a workup, because with those sorts of numbers, sure, we can do inseminations. And often while we're kind of working through that, we'll do a couple of rounds of inseminations. But if we've done a couple inseminations and we haven't had success, I want to know really why he's having those issues, and not just, and if they're pregnant in the meantime, great. And now we'll just have more information for baby number 2 down the road. But I like really trying to figure out what the underlying problems are that are causing those issues.
Exactly. And then the other thing is, if you happen to get pregnant, maybe freeze some sperm so that in the future, if the sperm counts go down even lower, you can use your younger frozen sperm. Great answer. Here's another question. I'm panicking a little. My egg retrieval was on June 6th, and here we are, June 16th. When should I get my period? I'm worried that my period won't come, and then my transfer will get delayed, meaning my frozen embryo transfer. What do you think?
Yeah, so some of this depends on what kind of trigger they used for her IVF cycle. These days we're using kind of one of two triggers, either an HCG trigger, which is like Novaril or Pregnel, or we're using Lupron triggers. If you use a Lupron trigger by itself with no HCG, you should get a period a little bit sooner, maybe like about a week after your retrieval. But otherwise, it should be about 2 weeks, about 14 days after your retrieval, she should be getting a period. So I think she'll be getting it in the next few days.
Exactly what I said. I've only had one patient that really didn't get a period after retrieval, and she ended up having a cyst. That's really never happened before. I mean, I know it can happen, but that's the only time.
Pretty rare.
I
definitely
haven't seen it. So rare. Here's another one about LH. So I'm using an analyzer and it says low or none on my LH surge. How do I get a more robust ovulation as opposed to a weak one? Is this a sign of poor egg quality or just poor ovulation? Feels like I don't have much of a chance and time is of the essence. How do I fix it?
Ooh, that really depends on what the underlying problem is that's keeping you from ovulating. I mean, when I hear that, it says see a reproductive endocrinologist, because we got to figure out why LH's surge should be surging after you've made a big follicle with an egg that's ready to ovulate. And so if that LH isn't surging, it's either not coming from your brain or you never made the big follicle in the first place. So we got to figure out the difference between those things so we can treat you.
Mm-hmm. All right, here are a bunch of questions from one person and they're all great. Do follicles stop after the trigger shot? Do they stop growing?
After the trigger, I mean, maturation of the egg happens after the trigger shot. So usually they don't grow a lot in size. Sometimes after you've ovulated, it'll fill up with fluid, but it's not really like the follicle growing like it was before then.
Yeah, I mean, I think sometimes patients see like a 16 and a 15 and an 18, and they get triggered and they hope that the 15 has time to grow. But if you've had the trigger shot, you're right. Maybe the ovary will swell and it will help with maturation.
Yeah, I mean, I've definitely gotten mature eggs out of 13 millimeter follicles though.
Totally. So. I've seen that before too. Okay, what type of frozen transfer protocol do you recommend for PCOS patients? I would really like to take minimal medications. Would letrozole be possible?
First thing with frozen transfer protocols, and I think one of Dr. Barker, I think, was writing about this the other day, is that every single place has their own FET protocol, and they are all variations on the same concept. And really, you have to look at what's worked best at that lab. But often in patients with PCOS, especially if they're not ovulating all the time, I really would recommend using some sort of medicated cycle. I think whether or not letrozole is an option really depends on how well you respond to letrozole and how predictable that is to work for you.
Right. Great answer. Great answer. Okay, here is another question from the same person. I have my retrieval on Thursday, but haven't had any blood work done. Should I be concerned? I want to do a fresh transfer, but how will the doctor know I'm suitable?
So she hasn't had blood work done. Ask that question.
It looks like maybe she's at a center where they're not doing blood work for her IVF cycle. And I know there's some people that don't do it. It's not that common, but.
Yeah, I mean, in general, we're pretty good at predicting, especially if they've been kind of watching the sizes of your follicles grow over the course of your cycle. Usually we're pretty good at kind of guesstimating when those follicles are going to be at the right size for trigger. So I don't know that labs on the day of trigger are absolutely necessary as long as your growth has been predictable through your cycle.
Right. I totally agree. Okay. Is there anything I can do to help with lining while I wait for my fresh transfer? I'm treatment day 9 on stim meds and my lining was 11 millimeters.
That sounds great to me. I don't think you need to do anything for that. Yeah. Put that embryo in when it's ready.
This is a great question. What are some good questions to ask at retrieval?
This will sometimes depend on whether or not you're planning a fresh transfer or a frozen transfer. One is just make sure you know what medications you're supposed to be taking from there on out. I mean, lots of times we spend so much time focusing all the medications you're supposed to be taking prior to your retrieval that it can get a little confusing after retrieval. And sometimes, at least at my center, we're kind of changing those medications depending on which trigger we give you at the last minute. So just making sure that those are crystal clear. Plans for pain meds if you need them, making sure you have the right person to call. I think the biggest advice that I give patients after the retrieval, especially if we're planning to not do a frozen cycle, to do a fresh cycle, is really, really listen to your body. And if you're feeling uncomfortable at all, let us know.
Yeah, totally agree. I agree. I think that's great. I mean, I think for patients to know when they're going to get their updates is really helpful. So ask that question before.
Oh yeah, when
who's
the lab is going to call you. Right.
Who's going to be calling me? What time can I expect their call? Because if you miss their call or you're in a meeting or something, you might be really upset that you didn't know that call was coming through. Okay. Here's another question. Another person asking a whole nother set of questions. On average, when will someone get pregnant with IUI? First, second, third? I'm 31, mild PCOS. I've already done one letrozole cycle. Also, at which point would you add injectables to an IUI?
Again, so much of this, I mean, I think from the outside, sometimes we look so cookie cutter because we do the same types of things. But in this, I'm going, this really depends on you. So if this is a patient with PCOS who hasn't otherwise been ovulating, and at 31, we would probably be a little bit more lenient with doing a few more extra cycles depending on her, because this may be the first time you've ever actually tried to get pregnant. And keep in mind at 31, our monthly pregnancy rates, assuming you're ovulating one egg at a time, probably sit between 15 and 20%. So, there's some studies out there that show that after 3 cycles of doing the same sort of therapy, that the people that are more likely to respond to it probably will. And so often for me, it's at that 2 to 3 cycle range when we start talking about maybe adding in injectables, but it is so personal and it depends on what you want, as the patient, and what your finances are, and what your chances are personally.
Yeah, and I think some people feel like they have to be more aggressive after 2 or 3 tries, but you don't always have to be. I'm sure you've seen it too. I've had patients get pregnant in their 4th, 5th, 6th IUI, even 9th IUI, and sometimes it doesn't make sense to keep going, and sometimes it totally does.
Right.
Okay, here's another set of questions from somebody else. If someone with PCOS does IVF, would they have less side effects from IVF since they already have so many follicles at baseline, therefore lower doses would be used? I'm thinking about doing IVF, but I'm scared of all the side effects and risks.
So this is kind of a 2-part question. One, yes, patients with PCOS often do require fewer medication. They don't need quite as much medication every day. But because you have so many follicles, you tend to have larger responses. I would say in general, a little bit more bloating, a little bit more discomfort in my patients with PCOS. However, patients do really well physically with IVF. I think I tell patients all the time that, you can be worried about whether or not it's going to be successful. You can be worried about the cost of IVF, but don't worry too much about the physical part of IVF because you'll get through it. And we've got ways to support you through the physical side of IVF. So don't let that part of it scare you away.
Right. I mean, I think people think it's lots of needles many times a day and then needles in the muscle of the buttock. And it doesn't necessarily mean that for everybody. For most people.
And I've never had a patient not make it through it physically. I've never had a patient not be able to finish. And that's, knock on wood over here. But yeah.
I agree. Okay. Secondly, what percentage of 31-year-olds with PCOS come out with viable embryos? Is the prognosis good?
Yes.
Yeah.
The prognosis is good.
Really
I think nationally, there's like a 5% cancellation rate for all patients under 35 with IVF. So patients under 35, only 5% of cycles don't make it to transfer something.
Right.
And so that's huge. And that's also including patients with really low reserve and things like that. So does it happen? Yes. Is it rare? Yes. That we have nothing to transfer.
Yeah. Okay. Here's another set of questions. Hi, doctors. I'm 31. I'm 14 days past trigger shot for my IUI, 12 days past my IUI. I took a pregnancy test this morning and it's negative, so I'm really bummed. Shouldn't it be positive by now if it worked?
We're real close.
Yeah.
I think you're right in that gray zone where probably it should be positive, but I've certainly seen incidents where it wasn't quite positive yet.
So now she's going to tell us a little bit about what she was on. She was on 5 letrozole, 2.5 milligrams a day. However, I had a ton of side effects and only grew 1 follicle after 23 days. I have PCOS. I still get a monthly period, but it's just 35 to 45 days. Do you think Clomid plus trigger would work better for me or at all?
I don't. I think letrozole works better. I mean, there's a big randomized controlled trial showing that letrozole is better in patients with PCOS. To me, it sounds like letrozole worked for her. She made a follicle and ovulated. I think, for her sanity, that was a really long time it took to make a follicle. So for her next cycle, I'd probably go up on that dose a little bit. So I'd probably increase her dose of letrozole with her next cycle, but we would want to ensure she was monitoring with ultrasound to make sure she didn't make too many follicles with that dose.
Totally agree. And some special sauce things I've done is like add dexamethasone. Even naltrexone is something that I also add with it. Taking ovasitol and other PCOS supplements like CoQ10, lipoic acid, and acetylcysteine. And then the other thing I recently did based on a study that I read was 10 days of Femara. I tried that in a patient who I tried 5. She was very resistant, even with all my special sauce. In 10 days, she actually is the one that brought me the study, and she made 2 beautiful follicles. And I was like, wow, this might be something that I need to start doing more and more of.
Interesting.
Like
I use a lot of those supplements and metformin in a lot of patients that I can't get to respond at all.
Yeah, totally. Okay, here are some more questions from somebody else now about IVF. Fresh versus frozen embryo transfer. Which has a live birth rate? Better one, and does it depend on the patient? What about patients with low ovarian reserve?
You could get people to debate till they're blue in the face on this
That's
one.
true. That's
For
true.
sure. Here's my take on it, because I know we're not a center that does all fresh or all frozen.
Right.
We do it on a patient by patient basis. So I go by the data that kind of says in patients that are normal responders, they're probably pretty equivalent. So in our patients where their estrogen levels are under 3,000, a fresh versus frozen transfer, now keeping it, let's just talk about our younger patients, are probably pretty equivalent in terms of transfer rates. For patients whose estrogen levels get really high, there's pretty good evidence out there that frozen would be better than fresh.
Yeah, great. And then PGTA testing. How do you know if it's right for you? How do you counsel your patients? And is it possible to do a fresh transfer and PGTA test and then do a fresh transfer and test the other embryos for the future?
Definitely. And I definitely do that. Again, a very personal decision based on looking at a whole lot of data. I think, again, in my practice, when you're looking at patients under 35, the data is pretty matched in terms of PGTA, in terms of overall success rate. So for those patients, we're looking more at like, what is your overall family size? Do you want to be banking embryos for the future? How important is that? How important is pre-screening for aneuploidy for you? I do think in my 36 to 40 patients, there's some value in kind of getting down to that embryo that we need to transfer for pregnancy rates. Right. Again, a really personal decision that is just going to require us to have a conversation.
Right. I totally agree. Okay. Here's a question about exercise in IVF. Cardio, spinning, running versus HIIT. Is one better? And is there a heart rate that patients shouldn't go over?
Oh man, I just love exercise in general.
Yeah.
I think I love HIIT workouts in terms of weight loss, but I think we have to, be a little bit careful with how hard we're stressing ourselves if we're talking about like actively going through fertility therapy. So I think in the therapy, then probably doing a little bit lower impact is a better idea, but I don't have a huge opinion on that. How about you, Aimee?
I'm with you. I mean, I feel like if your body feels good and you feel like you can work out with high intensity, do it. But I typically tell patients after about treatment day 4, treatment day 5, they're going to start feeling bloated. And at that point, you just got to slow it down. But up until then, even during your frozen embryo transfer prep, I mean, live life to the fullest. Like, don't let fertility take your joy away. And if joy comes from working out really hard, do it. Unless of course you have a really thin lining or your BMI is under 18, for example, then that's just a different story. Yeah. Okay. Here is another set of questions from one person, and I'll just go through it like one question at a time.
Okay.
Are luteal phase defects a thing?
I get this question a lot.
Yeah.
So my opinion on luteal phase defects is that it's not the making of progesterone that's an issue, it's the ovulation that's an issue. And by fixing and making you ovulate well, we generally fix the luteal phase defect. Now, I do use progesterone in patients that are having trouble with things, but I think what we used to call luteal phase defect is really an ovulation.
Yeah, I totally agree with you. So the rest of her question, I'll just read the next part. I have a day 21 progesterone of 4.7, luteal phase spotting starting 8 to 10 days post-ovulation. I've heard some people say that my progesterone over 3 is indicative of ovulation, that the actual level fluctuates throughout the day, while others have said that over 10 is what is truly normal. And then she shares her AMH 2.94, FSH 5.3, AFC 22. Is it more likely I have an issue with adequate progesterone secretion effect, or that I have an issue with egg quality? Is there a way to know? But I think you're right. I think you're right on.
So, I mean, progesterone with 3 is a person that's ovulated. If it's that high, one thing I see very commonly is that we're not getting it on the right day. We check a day 21 progesterone, and it depends on how frequent her cycles are coming. Very often what's happened, I see patients come from their OBGYN and they just automatically check a day 21, and they're a patient that ovulates on day 18 and just hasn't gotten high enough yet. So for spotting, I'm not sure that's an ovulation issue for her. I would be more inclined to think that was maybe endometriosis or endometritis or a polyp or something causing that spotting rather than an ovulation issue. But
and then possibly she could have maybe some mild PCOS because the AFC is 22.
22, yeah.
3, so.
Certainly, I would probably an early treatment would involve letrozole or Clomid or something to help with that anyway.
I agree. Okay, so here's someone asking an egg freezing question. I was in an egg freezing journey and my cycle was canceled on day 9 of injections. I had 57 follicles and only 5 responded to the injection, so my doctor felt it was best to try again. I had no indication things weren't responding until the day it got canceled. It was devastating. How common is this? And how concerned should I be that it could possibly happen again?
Communication is everything in our field. We make decisions on doses of medication based on your AMH, your how your ovaries look on ultrasound, and based on how other patients that we've dealt with similar pictures have responded to medications. And we like to think we make the right decision every time, but sometimes we don't. And certainly I've had patients that based on the amount of medication that I've chosen, we get an under response or an over response. And in this case, it sounds like an under response, but in this patient in particular, it really sounds to me like she has PCOS. I mean, 57 follicles is way above the normal range. Right. And so what we often see in PCOS is that they're fairly resistant to a certain threshold of medication, and then they just want to blow up because they've been holding on to all these eggs. And so it can be very difficult in PCOS patients to guess that initial dose, because we don't want to overdose and we don't want to underdose. So I think your doctor probably made the right decision, because 5 sounds low, but certainly I can understand where that would have been super frustrating when it happened.
Right. And you're so right, because it's like, wait for it. And you want to start at a low dose because you don't know if they're going to over respond. And then all of a sudden you increase your dose and you see the response you want, or you increase your dose and it's day 9 and you don't see the response that you want. So
right.
I've definitely been there as a doctor as well.
I think for this patient,
like
I definitely think she can make more eggs. I mean,
yeah,
I definitely think she'll get the response she wants.
Yeah.
So hang in there. It's frustrating, but you'll get there.
Absolutely. Now that they know your body, they'll know the special sauce for you. Okay, here we go. I'm 37 years old, AMH of 5. I'm freezing my embryos in a few months. I've started taking a variety of vitamins, supplements that were prescribed to me, and now I eat mostly a Mediterranean diet. However, I have a serious sugar addiction. I eat well during the day, but after dinner, I eat anything that's sweet within reach. Chocolate, lollies, ice cream. Given that I have a low AMH, so I think she says her AMH is 5, but she's overseas, so the
I was going to say, I think it's a European, low. Yeah.
Yeah, totally. Am I risking my egg quality by eating so much sugar? My biggest fear is doing a retrieval and getting no embryos. Love sweet eggs.
You know, I don't know that we have a lot of data on sugar consumption and egg quality. I think we assume that probably sugar is not great for things. And we know that if we're insulin resistant or we have diabetes, we know that affects egg quality. And so I think our gut response is to say, hey, try to cut the sugar out of your diet. I don't know that I have any good studies, or I mean, you may, that say like you make that change in your diet if you don't have any of those underlying issues, and that will make a difference though. So I kind of hate to take her lollies away unless I know it's going to make it any better.
Yeah, I mean, just a serving here and there is not going to hurt. I don't think striving for perfection doesn't mean taking away the things, like I said, that bring you joy. So you're right. Yeah. I totally agree. Unless, of course, your BMI is high or your A1C is high. And,
yeah, I think you'd have to look at what her underlying, medical issues might be that might mean that meant something for her.
Right. Cool. Okay. Hi, I'd like to ask this question on today's live. Thank you so much. My husband's sperm analysis came back, air quotes, normal. They never gave me details. For our first IUI, they said his sperm at post-wash was 34 million. They didn't mention anything about motility or morphology or anything. Is that a good, very good, or average level? And why no mention of the other 2 criteria?
Very good, and probably because it was so good they weren't even they didn't even think to mention it. I mean, for a semen analysis, for example, when we use donor sperm, they break it into aliquots of 10 million per unit that we have because pregnancy rates are great over 10 million. So 30 million is fantastic. I think they just thought that's a great sample and just didn't go into the details.
Right. I agree. Okay, here we go. I'd like to tell you a little bit about my experience so far. I'm 30 years old, PCOS since the age of 22. My husband's sperm showed low motility, low morphology, so the doctor suggested IVF. For our first IVF, we started at 24 eggs retrieved, which I thought was really great, 13 fertilized normally, and it sounds like 4 fertilized with ICSI, so it sounds like they did some ICSI, some without. On day 5, we had 4 embryos, blastocysts, BB quality, and we're going for PGS screening. We don't have the results yet. Question number 1, do you think I'll get pregnant?
Yes.
I'd like to say yes.
Yeah, I do. Yeah.
I
do
know. I
think
really
so.
want to say
Yeah.
yes. I mean, I love that question. I'd like to say yes. I mean, chances are good.
Yeah, chances are good.
30 years old. Okay. Do you think 4 embryos is a low number considering we started at 24 eggs with PCOS and being 30?
This is the hardest part about IVF. There is a huge attrition from the number of eggs we start with to the number of embryos. And somehow, I mean, I can still remember back to being, a resident and a fellow being like, oh my gosh, she had so many eggs. And that's just, and I think, we have kind of gotten used to that. And we know that that still means that these patients have really good outcomes. So I think that just kind of goes with it. The way I kind of like to explain it to patients sometimes is like, you've come with 12 months of putting out eggs. So you put out 12 eggs and haven't gotten pregnant. So if we can get 22, we're giving you 2 years worth of trying. And it would make sense that we would only have that kind of,
that's a great way of
we
thinking
as humans
about it.
are just really inefficient at reproducing. We were made
suck
to have,
at it.
We are really bad. I wish we were mice so badly.
I know.
But we're working against a system that just is not an efficient one. And so what we see that in IVF all the time, but I generally tell patients they're going to get between 1 and 5 embryos, hopefully.
Right. I agree. And it depends on your age. And oh, there she is. No worries. No worries. Okay. So here's another question. At what point does one switch to a normal OBGYN once a pregnancy is achieved?
This varies by state. Every state kind of, and then just regional differences in kind of when OBs tend to see patients for their first prenatal appointment. And so usually I think as REIs, we kind of fill in that space. So I've worked in states where they tend to see patients more at 8 weeks. And so we'll graduate patients at 6 weeks, but like here in the Midwest, often it's more like 12 weeks for an initial OB visit. So I see patients until 10, 11 weeks in my practice all the time.
Yeah, I think things have changed a lot. I think as women are getting older, starting their families, especially in the Bay Area, it used to be 12 weeks. And I feel like now, and I think it's great for patients that it's kind of moved to like the 8 to 10 week. Yeah, same thing as here. Okay. I'm unsure after so many hormones during IVF, how is my hormonal profile going to be maintained magically on its own if I achieve a pregnancy through IVF?
You don't need all the hormones once that placenta takes place. The hormones that we're making from our ovaries are supporting that pregnancy for probably the first 7 weeks of pregnancy. And beyond that, then that placenta is in the uterus and you've got that blood supply going with mom and that is supporting itself. So we are just supplementing things until that happens. And we usually over-cover you by a few weeks.
Right. As a PCOS patient, how should I take care of myself to make sure my pregnancy happens and stays?
Eat real food, exercise, don't eat a lot of added sugar. For you, the lollies matter.
Yes.
Yeah, it's not, there's no crazy recommendations. There's supplements that we can talk about and things like that, but
I think you're right. Get your levels checked and make sure your metabolic parameters are normalized before you get pregnant. That's really the best thing that you can do. And after that, if you have a healthy embryo, it has a really good chance of sticking. Yeah. Okay. Here's another question. Hello. I would like to ask you, I have so far gone through 5 IVF cycles with fresh embryo transfer, 1 with a frozen embryo transfer. I'm using an egg donor. I just have 1 frozen egg donor embryo left. What should I do? This is someone who's gone through egg donor IVF and it seems like hasn't had success and has 1 left. And it also seems like they're not in the US.
Again, I mean, this is a why is that happening kind of question. Right. The one thing that I see a lot causing that here in the Midwest is endometriosis or adenomyosis. So that's something I would look into if it hasn't been looked into, because I've had a lot of Lupron suppression transfers that work a lot better in those patients. So.
Right. And maybe if you're not here, here we'd have access to the ERA test, the Receptiva test. And if you don't have access to that, potentially maybe just like you said, take Depo-Lupron or do some sort of suppression, assuming that there might be some sort of inflammation going on. Take a good look at the cavity and do all the healthy stuff that we talked about. Great answer. Okay. My husband and I are now at such a loss of where to go from here, and we'd love your advice. We have gone through 4 failed donor egg cycles with 2 different donors, and all embryos were PGS tested. I have stage 4 endometriosis. We feel that it has never been considered, and I also have a retroverted uterus and wonder if this can cause some technical difficulty with the frozen embryo transfers. It's been the same doctor every single transfer. We've spent a lot of money and feel we're no further forward, and ultimately we're no closer to getting our very much wanted baby, and our hearts are broken and we feel like we're running out of options. Any help or advice would be very much appreciated.
Oh my gosh, so much love, first of all.
Yes.
Oh my gosh, that's a tough one. I think I was just saying that. I really, in this patient, if she hasn't done it, I would do 3 months of Lupron before her next transfer.
Yeah.
I think that might make a big difference for her.
Yeah. And the other thing, if the same doctor over and over is having technical difficulty with your transfer and it's really hard to get the catheter in, do your transfer asleep under anesthesia.
Mm-hmm.
You know, there are things that you can do while you're asleep under conscious sedation, and it's not going to hurt your embryo to do that you can't do if a patient's awake. So sometimes that's a really good way. You know, you can get the bladder at the perfect filling as well before you do the transfer. Mm-hmm. Okay, here's another question. What can you do I think I get a cervical mucus question every single day. I do. Cervical mucus is very popular to talk about. What can you do? Everyone wants to know to increase cervical mucus. If you don't have much of it, does that mean you're not ovulating or can't get pregnant?
I know. I just stop looking at your cervical mucus. Why? I mean, we make cervical mucus when we have a lot of estrogen, you know, that's what it comes down to. So if there's a problem with your estrogen, but I don't know. What do you think with the cervical?
I mean, I think sometimes people feel like they don't have cervical mucus and they really do, and they don't understand that what they have is actually amazing and perfect, and you know, they actually do have really great mucus. So for example, I'll do an IUI for a patient, I'll place a speculum, I'm like, oh my gosh, you have so much cervical mucus, and they can't sense it and they don't see it. So they're just not able to. So there's a cool device. I'm actually getting one on Friday. It's called the KEGG, K-E-G-G. Okay. And I think for patients who really want to learn as much about their body, even their cervical mucus, you can actually stick this little device inside your vagina, and it actually measures all sorts of parameters about your cervical mucus. And then it's Wi-Fi enabled and shows you like where you are in your cycle and fertility and how fertility friendly your mucus is. So I'm curious to see how it's going to work on me with my cycles. I just like trying out different things. So that'll be interesting to see how that goes. Okay. So we're all done with our questions that were emailed in. Okay. So now
I see Haley, our lolly girl, is giving us she's her BMI is good. She's going to go keep having her sugar. I love it. Okay.
I love it. Okay. So I love it. So I'm starting at the top. Oh, this is awesome. So someone just said, so excited to be here all the way from Nigeria. It's midnight here. I stayed up to 10. Thank you so much. Okay.
Thank you.
So here we have Olivia who's asking, how long should I try before becoming worried? And that's all the information we have. So what would you say to someone?
Okay. 36 and above, 6 months. Getting closer to 40, just come in. Don't even try.
Yeah.
Under 30, 34 and under, don't wait a year if you have painful periods or even like cramping in the couple of days leading up your cycle. If you need Midol every month, if you're taking medications, if you have a known history of having pelvic infections or PID, if you have a male partner that has known fertility issues, or if you don't get a period very predictably every month. Don't keep trying at home. See someone way sooner than that.
I agree. And if your husband's testicles are small, sometimes people, easy check.
Or has a history of torsion or something like that. I mean, sometimes if you kind of ask about that and they don't know about it, the Tushy method. I love it. Yeah,
it doesn't show up straight, but get your Tushy checked. Okay. If you don't know what that is, go to tushymethod.com. Okay, here's another question. I got a combination of Lupron and Pregnal for my trigger shot. Why would a doctor prescribe this?
So those are two, I was talking about a little bit earlier, there's 2 different kinds of triggers we use for the IVF cycle. One is HCG, that's the Pregnal, that's the brand name Pregnal for HCG, and the other one is Lupron. They both work in different ways to trigger ovulation. Often for patients, we give them both because it depends on how they respond during their cycle, which one they want to use. Or in some cases, we like to use a combination of both of those to get a better egg yield. So they're both triggers for ovulation, and it kind of depends on your particular situation, how we want to use them.
Perfect. Yep. And then another question, is there anything you recommend to do after a frozen embryo transfer? What are your do's and don'ts? Foods, eat. That's probably the number one question I get after the transfer. People ask, is there anything I can eat or anything I can do to make this work better?
Have fun. There was a study with clowns and laughter and saw better pregnancy rates in people that were laughing. So I love comedy. I just tell people, don't go ride a mechanical bull at the bar. And don't go run a marathon. That's it.
I love that. I need to incorporate that in my post-transfer instructions. Do not ride a mechanical bull. I mean, that's so much better than what I say. Okay. Here's another question. I received my results for my BCL6 level and it came back negative. I'm waiting on my ERA test that I also had done. I'm nervous. What's the worst case scenario?
It's negative.
Yeah.
No, and positive. I mean, I don't know what the worst case. What do you think? I don't know how to.
Oh, I would say the worst case scenario for an ERA test, honestly, is like insufficient DNA, and you have to do it all over again. I mean, that's really, ERA test isn't a yes or no test. It's more like, this is your number. This is your personalized number. This is the number of hours that you need of progesterone in order for implantation to occur. So that's really the worst case scenario from the ERA test.
Yeah, definitely.
Okay. Here's an OHSS question. What can I eat after retrieval to prevent OHSS?
Protein, electrolyte fluids, low sugar carbs. Mm-hmm. Yeah, those are usually my recommendations.
Yeah, whey protein, drip drop, liquid IV, those little powder packs, those are easy. And then some other meds like bromocriptine, Femara. Sometimes they even give ganirelix for a few days afterwards, or the Cetrotide to also help.
We can use medication to help too. Mm-hmm.
Absolutely. Okay. How do you coach patients through post-egg retrieval depression or emotional fatigue?
One is that we have some great counselors that we work with, and I let them do what they do best. So I hand out their card like candy in my office, and I think they're awesome. I have other patients that love going to acupuncture, which I think helps too. I think I think communication is key too. I think setting expectations for what we're going to be looking at for preparing patients to know that 22 is going to drop to 1 or 2 or 3, and that's okay. That's what we're expecting. That still is going to give them the outcomes that we talked about from the very beginning. So I think some of it is about managing expectations from the beginning so that we don't kind of have to ride the roller coaster quite as steeply as we anticipated from the beginning.
I love it. Okay, thoughts on a mini IVF with low hormones with a low ovarian reserve. I've heard conflicting thoughts on whether mini or extra high doses of hormones is most effective.
There are conflicting opinions on that. That's why you've heard that. I think the data is generally that traditional IVF is better than mini IVF. However, when we get to those patients that aren't responding well, that are spending thousands of dollars on medications and only getting 1 or 2 eggs at a time, that we start to get to a situation where doing mini IVF, it's going to give us the same 1 or 2 eggs for a fraction of the cost. And so those are the patients that I talk to about moving on to protocols like that.
Yeah, I agree. I said more is always more, but less is more when you always have less.
Perfect.
To get more, sometimes you need to use less.
Yeah.
And then I confuse myself because I'm like, what did I just say?
Did I say that right? Right.
Did I say that right? Okay. Here's another question. If I'm freezing eggs and I get less than 5 eggs per egg retrieval, is that a sign that my eggs are probably not very good?
No correlation between egg quantity and egg quality. So no, I mean, in fertility, we like to have more eggs because it gives us more chances, but we have no way of predicting that egg quality until you try to use them.
I agree. And it also depends on your age. So using your age in that scenario would also, or knowing that your age would help in that scenario. Here's another question. How much does stress affect the quality of eggs?
I wish I knew.
Yeah, I know. I mean, I feel like the research says, if you look at some of the most respected psychologists, they say stress doesn't affect fertility, but at the same time, I just feel like, how can it not?
Right.
And so I want my patients to go through their treatments feeling really well and have low stress. So obviously, like what you said, giving out information about how to get support is very important. But, I have patients that say, I'm so stressed, I want to wait 2 or 3 months until I'm less stressed to cycle. And I don't know that that's really helpful.
Yeah. I mean, one of the things I tell my patients all the time is that, when we're looking at IVF, I've yet to meet an IVF patient that isn't stressed.
Mm-hmm.
I've yet to meet that. So when we are looking at our data with IVF, we are looking at our data in a stressed population of patients. Everybody's stressed.
Yeah.
So our outcomes are based on people that are stressed just like you are. So keep that in mind. I mean, do we see patients that experience more stress than others? Sure. But I mean, I've had very few that are just like, this is a walk in the park. Like, this is what I want to do every day. So keep in mind that despite that stress, we still see the outcomes that we see with IVF.
Right. That's a really good point. Yeah. I mean, I feel like if you're waking up with panic attacks and you can't sleep at all at night and you can't get back to sleep because you're waking up in a sweat, that's a different story.
That's
right?
a different story.
But
we have to get
part,
through the IVF cycle.
Yeah,
right. Yeah.
Totally. Okay. Here's another question about sperm. When would you recommend a sperm DNA fragmentation test?
You know, I'm starting to get them earlier and earlier. I was getting them in kind of borderline analyses before IVF. First, I was getting them in IVF, poor fertilization when it looked like a pretty normal semen analysis. Now I started to get them before IVF, and now I'm starting to get them a little bit earlier to decide whether or not we might need IVF. So.
Right. Yeah, I totally agree. I especially get them now because I have more and more patients who are over the age of 45 having babies, and a lot of their partners are over 50. And so I feel like even with good sperm, it just makes sense to get it in that population too. Okay, here's a question. I'm 41 years old with endometriosis, and I've gone through IVF testing. I've gone through IVF and I had a miscarriage. I have 2 frozen embryos left. They weren't tested. Would you suggest having another egg retrieval? That's the question.
Was her egg retrieval just done? Do we think it was just done now? Like it's.
I'm thinking it was recently done. I'm thinking her eggs that resulted in the miscarriage was probably
just
pretty
from
recent.
recently.
Yeah.
I mean, the fact that she made 3 embryos, I would consider doing that and PGS test. Doing another cycle right now. Sure. Yeah.
Yeah, I agree. Especially if you have endometriosis and you want to treat it. If it's severe, you might want to get more embryos first before you suppress yourself for a while, and then
Correct.
Your opportunity to do cycles later it's not as high as far as, you know what I mean, age-wise.
Yeah,
Okay,
totally.
Here's another question. I'm 42 and I did donor eggs and I only got 1 day 6 embryos. Is there anything you recommend I do before I transfer? What would you do?
I'd probably do an ERA and maybe Receptiva, and I maybe do all those testing before doing that. When we got all our egg in one basket.
Exactly.
Do it all.
Here's a question about immunity. Do you have an immunity protocol for known autoimmune patients who have poor to 0 eggs retrieved?
Shoot this one at you, Dr. Aimee. I feel like
my thing is that I always tell patients if obviously you have an autoimmune condition, then that's a different story. But
yeah,
I feel like when you start checking people for like their ANA, I mean, 15% of the population is going to be ANA positive and doesn't mean anything. And then I see other doctors putting their patients with no symptoms, like no joint pain, on steroids. That just doesn't make sense to me. Because if you really had a problem, steroids would help if you had, let's say, joint pain. And then, for true abnormality, we use medications like Plaquenil. And so I don't necessarily want my patients to be on those drugs because it can cause so many side effects. So I feel like a lot of the reasons why IVF doesn't work might be related to some sort of immune dysfunction between the embryo and the uterus, but I don't feel like it's something that we can treat. I think a lot of the times it's genetic. It has to do with these genes that are called HLA genes inside the embryo and the KER genes in the uterus, and they just don't match up. And I don't know if there's anything we physically can do to make that happen. It's a very frustrating experience having patients who go through transfers that don't work. But when I have a patient that says like, hey, I want to do immune testing, I say, sure, I have the kits here. And then I tell them, look, almost everyone has a problem on these tests. I don't know why, it just seems to be that way. And then I send them over to the infusion center for intralipids, just like going to Jamba Juice, but getting your smoothie through your vein,
Yeah.
If you want to do it, you can, but it's not necessarily.
I don't think our testing, I don't think our testing is accurate enough. I mean, we know that natural killer cells of the uterus are different than the ones we're testing in the serum. So I kind of think if we think that's the problem, we just treat, I do use prednisone sometimes, but mainly in patients that have known autoimmune disease.
Exactly. So is it terrible to have back-to-back egg retrievals for IVF? What other vitamins during this process, aside from prenatals, do you recommend?
Patients usually end up needing like 1 cycle in between just because they often have cysts left over. So often it's like a cycle, an IVF cycle, a regular cycle, an IVF cycle. So it ends up with like 1 month in between, but there's really nothing wrong with that. In fact, we may just be grabbing the extra eggs that were kind of being recruited during that first cycle by doing that 3 months later.
I agree. I think sometimes if a patient, say 43 or 44, depending on the situation, I'll say show up at that next period start. If your ovaries are swollen,
we'll
you won't
try.
start.
Right. Yeah.
If it's not, we'll go for it. Okay. How many eggs should a 37-year-old freeze for one expected pregnancy?
What do you tell your patients?
A lot, because you just never know.
As many as you can.
Guess what? Well, no, the thing is this. You have that one baby and all of a sudden you're like, oh, I really wanted that second, you know?
Yeah.
So I tell my patients, look, you want, maybe be open to doing 2 or 3 egg freezes. You'll never regret freezing more. You'll only regret freezing less. And, I have a little egg calculators that I just put in their follicle count, and then I tell them how many retrievals they'll need to do to at least get close to a 75% chance of having one baby, and go from there. So here's another question. I'm 30 with PCOS in Nigeria. I've been married and trying to get pregnant for 5 years. I'm starting my IVF cycle next month, and I hope to get pregnant with twins. How do you recommend I prepare for success?
Well, I think do your IVF cycle. I think that's probably the most important thing. With PCOS, looking at your diet and trying to cut back on carbs and sugars and things in your diet. I think the twin thing is a hard one that we look at in terms of overall kind of development in children. But that's a whole separate discussion there. Right. But yeah, I wish her the best for her cycle.
Yeah, I've definitely had patients with PCOS have twins. There's no doubt about it. But yeah. I feel like, maybe transferring one at a time would be better. I agree with you. Okay. You mentioned that painful periods is a risk factor when trying to get pregnant. Can you talk more about what level of pain is normal and what level of pain would be abnormal?
Yeah. So what we're screening there is for endometriosis. And just briefly, endometriosis is where the cells that line the uterus that we shed every month when we get a period, you can implants of those outside in the pelvis. They actually bleed every month around the time of period. So usually the symptoms of endometriosis are discomfort in the couple of days or a week or a day leading up to your period, usually maybe into day 1, and then it kind of goes away. Mm-hmm. That pain can be incredibly variable. And we all know as women, someone for whom it was debilitating. We all know, Susan, who had such bad endometriosis that she missed class and took heating pads and would miss work and all those kinds of things. But that, in my experience, I do a fair amount of laparoscopy for endometriosis. That isn't my average patient. My average patient, I kind of have to pull it out of them. I often get the response, well, I just have normal cramping. Right. And I said, well, what is that? I often use the question, and as someone with endometriosis, I'll say this is true of me. Like if I wasn't tracking my cycle, if I wasn't trying to get pregnant, I didn't know when my period was come, I would be surprised that I started bleeding that day. And if I say that, and that just totally blows your mind that that's possible, then you might have endometriosis. Right.
Absolutely. For sure. And I think as women, we're so used to being made to feel like pain is normal. Mm-hmm. And then by the time they've come to us, they've talked to so many doctors, and the doctors have kind of poo-pooed their complaints so that they don't feel like it's something that would matter to us. And it totally matters to us.
And socially, when 1 in 10 women have something, it is very easy to find other women in your social circle that have the same complaints. And it's only women experiencing those that are going to be talking about it. So you can very quickly surround yourself by other women having the same symptoms and normalize it even more. Right. Plus, we're just incredibly resilient humans. I have horrible allergies. I think it's totally normal to carry Kleenex everywhere you go, and take Zyrtec every day. That's what everybody does, right? I've just learned to cope with it in my daily life. And so I think that the same thing happens. Over time, you adjust your life to deal with the discomfort you've had until it becomes something you don't even notice anymore.
Right. I agree. Okay. What's the optimal size range for follicles that trigger?
15 to 22.
Yeah. Cool. Can I get pregnant naturally with an 11 millimeter egg?
It's a little small.
Yeah. And if it was 11 millimeter, it's probably going to be bigger. Maybe it was bigger the other day, right? Okay. Is it normal to have period-like cramps a week before periods are due, and again 2 days before your actual period?
That sounds like endometriosis.
Yeah.
I'd get checked out for that.
Absolutely. Or like you ovulated, your ovaries, swelled a little bit afterwards, and then it went away. Okay. Who makes a good candidate for a fresh transfer? Are there specific limits for progesterone levels, estrogen levels, and lining thickness?
Estrogen under 3,000, probably ideally in the kind of thousands or below. Normal progesterone levels. Yeah, that's my main criteria.
Okay.
Number of eggs retrieved in the teens or single digits.
Right. Okay. Could high DHEA sulfate alone be the reason for my infertility? Mine has been around 400 for a year.
I wonder if that's not a sign of PCOS, maybe, for that patient.
Right. Yeah, I agree. Hi, I'm 37. I have a polyp with a FSH of 10.3. Should I have the polyp removed and try naturally or go straight to IVF?
How old are they?
37.
37. I would probably have the polyp removed and go to IVF.
Yeah, I mean, totally. I mean, I like to get patients ready for a possible transfer because, like, what if, you know, that embryo needs your uterus and then you're not ready because the polyp's there and you don't have options, at least knowing that the polyp could grow back. It just kind of depends.
And honestly, I'll back up on that. I think for this 37-year-old, depends on what her family goals are. If this is her first child, I would probably go straight to IVF. If she's got 3 kids and she's trying for 1 more, sure,
get her head
do some
examined.
IUIs. Yeah, right.
I have 4 kids. I can say that. I'm allowed to say that. Okay. How do you tell the difference between a cyst and a follicle?
Initially, they look exactly the same.
Right.
Time. Redoing an ultrasound at a different time to see what it looks like later.
And sometimes hormones can tell you. I mean, you can be tricked by hormones, but sometimes a high estrogen, a really low progesterone, and then over time, and it's still the same. Or if your progesterone's high, you know you're ovulating. That's kind of one way to tell. Okay. How is sperm chosen for ICSI?
They run them through a little obstacle course in the lab. I'm joking, but it's kind of true. Yeah. They run them through a gradient in the lab, and the winners get to be used for ICSI.
Exactly. I mean, you have to be the best looking sperm cell, and they can seriously
They put little
tell
capes
with
on
a
them,
microscope.
and they let them just go.
Yeah. I wish. Yeah. I mean, I think some of the videos that we get to see of stuff in the lab, patients are seeing more and more of because of Instagram and stuff, or in YouTube, and it's really cool. Meredith, we're done. We did it.
Yay!
Almost 5 pages, single space type of questions.
And I'm only sweating a little bit.
I know, right? Okay, last question here, and we're going to sign off for now. Thank you guys all for joining us. This has been awesome. So great.
Such good questions.
Have you ever seen 10 plus empty follicles at retrieval despite follicles between 14 to 23 millimeters? Why might this happen?
Sometimes you've already ovulated. Mm-hmm. Sometimes you needed a different trigger. Those are probably the 2 biggest reasons I see that. Or sometimes I see that with just really bad PCOS, where they just have a lot of empty follicles, or the extremes of age. Yeah.
Right. Immature eggs. I agree. Are cramps before, last question, now I promise. Are cramps before a frozen embryo transfer normal? What are some reasons an FET would be canceled?
Not necessarily normal, no. FETs are canceled not infrequently with certain protocols if you've ovulated before we start your progesterone. So most clinics that are doing a medicated cycle will test a progesterone level before starting your progesterone injection. So that's probably the most common reason that we would cancel an FET, unless like the embryo didn't freeze and that's all I had later on.
Totally. So when I tell my patients that I use doxycycline before transfers, do you?
Oh, sometimes. Yeah. And
I just use it on everyone, and it can just totally mess some people's stomachs up.
Yeah.
And then they start cramping and they feel like something's wrong. And I'm like, it's the doxycycline to stop it. Yeah. Most of the time that helps. Okay. Sure. Well, thank you guys for all the positive feedback and the love. Meredith, can you just tell everyone where they can find you one more time?
Okay. Meredith Provost. I'm a fertility doctor at Indiana Fertility Institute, but you can find me at Meredith Provost MD on Instagram, Meredith Provost MD on TikTok, and Dr. Provost on Twitter.
Awesome. Okay. Well, thank you again. Have a great night. Have a great night, everybody. And
thanks,
hope
Aimee.
to see you soon. You're welcome. Bye, guys.